everyone, this is Dr. Garima, one of the mentors of StudyMEDIC, and today, continuing with our RRR series, the topic that I would be discussing is amenorrhea, menopause, and hormone replacement therapy. So we'll start with a quote that time is non-refundable, so we all should spend it very wisely. Then starting with primary amenorrhea. So this is a flowchart from one of the NHS recommendations. I'll just go through it one by one. First of all, what is the definition of primary amenorrhea? So primary amenorrhea is defined as if there is failure to establish menstruation by the age of 16 with normal sexual characters, by the age of 14 with no sexual characteristics. So if anybody comes to you with primary amenorrhea, you should, if she's of the age of 16 or 15, you should look for the secondary sexual characteristics to classify it as primary amenorrhea. Then you have to look for associated complications, whether there is some sort of osteoporosis or bone loss, any sort of cardiovascular disease, infertility, psychological distress. Then you have to do a detailed history regarding the family history of similar problems. You have to exclude pregnancy if she's sexually active. Ask for cyclical lower abdominal pain without bleeding to rule out obstructive causes. Ask about the development of secondary sexual characteristics. Take a detailed sexual history. Exclude pregnancy. Ask about previous chemotherapy or radiotherapy. If she's on any medications, any history of illicit drug abuse. Inquire about hypothalamic dysfunction. Then these are the possible causes which you have to think while you are managing a case of primary amenorrhea. So they could be because of because of pregnancy, or most commonly they might be just constitutional delay. These two are physiological causes. The pathological causes include any genitourinary malformations, PCOS, hypothalamo-pituitary dysfunction due to any chronic illness, stress, excess exercise, androgen insensitivity syndrome, ovarian failure, gonadotropin deficiency, 5-alpha reductase deficiency, congenital adrenal hyperplasia, and androgen secreting tumor, which is quite rare. This is about history. Now moving on to examination. So important things you have to check for is the BMI. Look for signs and symptoms of hirsutism, abdominal distension, Turner syndrome. Look for breast development, secondary sexual characteristics, androgen insensitivity, presence of hair in axilla or pubic area, thyroid disease. Do a detailed pelvic examination. Inappropriate if it's young girls, usually you do not do it if they're not sexually active, but if they're sexually active, you can do that. Okay, then this was about history and examination. Now moving on to investigations. So important investigations that I'll do is FSH and LH level, the total testosterone, prolactin levels, TSH, beta HCG to exclude pregnancy, and pelvic ultrasound to rule out any sort of structural abnormality. And you have to, if she gives a sometimes if somebody is doing vigorous exercise, that can also result in amenorrhea. If it is exercise associated, then you have to refer them to the sports specialist and the health specialist so that they can give a proper diet plan and regulate their exercise accordingly. Otherwise, you consider referral. And whom would you refer? You'll refer to the gynecologist in the girls with normal secondary sexual characteristics who have who have not started menstruating by 16 years. Refer to pediatrics if they are. This is at the level of the GP when the GP is considering referral. Girls not menstruating by the age of 14 with no secondary sexual characteristics, to a counselor if you're suspecting stress-related amenorrhea or exercise-related amenorrhea or anorexia nervosa, something like that. An endocrinologist if you're suspecting any hormone disorders like suspected hyperprolactinemia, thyroid, or other signs of androgen excess. Now, going to further evaluation and management. how do you make the diagnosis? So first of all, you see whether secondary sexual characteristics are there or not after your detailed history and physical examination. If there is absence of secondary sexual characteristics, then you do FSH and LH. If FSH and LH is low, less than 5, then you think of problems at the level of hypothalamus and pituitary. So these could be hypogonadotropic, hypogonadism, example, mostly constitutional. Other things could be delayed puberty, anorexia, and other causes. If FSH, LH are on the higher side, that is FSH more than 20, LH more than 40, then you think of hypergonadotropic hypogonadism, that is gonadal failure or ovarian failure. In these cases, you do a karyotype. If it is premature ovarian failure, then the karyotype will be normal 46XX, or sometimes it could be Turner's, where you get the karyotype as 46X4. This was about if secondary sexual characters were absent. In case the scenario is the other way, that the secondary sexual characteristics are present, then you do an ultrasound to look for presence or absence of uterus. If uterus is absent or abnormal, then again you go for karyotype. And if the karyotype is 46XY, the diagnosis is androgen insensitivity syndrome. And if it is 46XX, the diagnosis is Mullerian HFSS. On the ultrasound, in case the uterus is present and normal, then you rule out chances of outflow obstruction. And the major causes which can result in outflow obstruction are imperforate hymen or transverse vaginal septum. So you can examine or do an ultrasound, 3D ultrasound or MRI to rule out that. And if there is no outflow obstruction, that's also ruled out, then you again move on to ruling out secondary causes or causes of secondary amenorrhea. So this was about diagnosis of primary amenorrhea. Now moving on to secondary amenorrhea. So secondary amenorrhea, primary amenorrhea we've already discussed. If by 14 means no menses without secondary sexual characteristics, and by 16 with normal secondary sexual characteristics. However, secondary amenorrhea is no menses for 6 months in a patient who was already having periods, normal periods, or oligomenorrhea is defined as periods that occur at interval of more than 35 days to 6 months, or having less than 9 cycles per year. So this is the clinical definitions of primary, secondary amenorrhea and oligomenorrhea. Now, for investigation of secondary and oligomenorrhea is almost similar. So how do you start with? Always history, examination, investigation. So in the history, you ask about age of menarche and detailed menstrual history, any recent weight change, any dietary changes, any exercise history, stress level, any history of recent travel, medications or drug history, history of illicit drug abuse, sexual history, contraceptive history. Because if somebody is on prolonged contraception, like they're using Mirena or even prolonged use of OCP, can cause amenorrhea. You take a obstetric history, and if there is delay in investigations until 9 months, if obvious cause like exercise, sports person, like if they have a history, then you can wait for some time and just start treating by referring them to the exercise specialist and the dietitian. Examination include height, weight, and BMI, hirsutism, examination of the skin, visual fields, because sometimes the visual fields are also affected in particular causes. Investigations you exclude for pregnancy, do thyroid function test, hormone profile from day 2 to day 7 of the cycle. You check for FSH, LH, estradiol, prolactin, testosterone. Check for fasting glucose, glycosylated hemoglobin if the patient is obese. Do a pelvic scan to assess for endometrial thickness and look for polycystic ovaries. Bone mineral density scan in women with low estrogen and amenorrhea. Now, how do you manage? So, if a patient is trying to conceive, you refer them to fertility specialist. If they have normal investigations and they have no if they're not thinking of conception, then you can re-advise and advise regarding contraception, review in 6 months, and if persists, repeat all the tests and refer to gynecology. If it's a polycystic ovaries, then in those cases, you advise them regarding weight management if the BMI is raised. And in case the patient has some signs of insulin resistance, then in those cases you can start metformin. Otherwise, routinely you will not do that. And if there is hirsutism and acne, contraceptive pills are the best for the treatment. And if they're persistent, then you manage by giving anti-androgens. Raised androgens, you generally refer to endocrinology. Raised prolactin, you consider causative medications like rule out drug-related causes like risperidone, olanzapine, SSRI, phenothiazine, metoclopramide. Do not stop mental health medications without specialist advice. This is very important. Even if the prolactin is raised, you refer them to mental health specialist and let them assess the patient. If the prolactin is more than 1000, then you have to repeat in 6 weeks and you have to think of prolactinoma. Check macroprolactin levels. If prolactin is still 400 to 1000, you give combined oral contraceptive pills and repeat in 3 months. It's still 400 to 1000, you continue OCP. However, if it is more than 1000, then you have to think for prolactinoma and refer to endocrinology. For hypogonadotropic hypogonadism, low estrogen and low FSH, you offer weight gain if the patient, you feel it's because of anorexia nervosa or bulimia nervosa, you offer them weight gain advice and dietitian referral if appropriate, and refer to mental health if there is any eating disorder. If prolonged amenorrhea, check bone mineral density, consider estrogen supplements. For menopause and premature ovarian insufficiency, where the FSH should be very high, in those cases, you manage according to the menopause guidance. These patients would require HRT until the natural age of menopause. So this was about diagnosis and management of secondary amenorrhea. I hope this was clear. Then moving on to the next topic about menopause and HRT. So how do you decide what HRT to give, and how do you initiate HRT? What in various scenarios, how do you decide whether you have to go for sequential, whether you have to go for transdermal, whether you have to go for combined HRT? So this segment is basically focusing on that. So whenever a patient of menopause comes with menopausal symptoms, you have to do a detailed counseling, rule out any contraindications, relative or absolute, for HRT. And the indications of HRT include if there is menopausal symptoms, premature menopause or ovarian failure, there is risk for osteoporosis. Now, deciding for HRT, what type of HRT? First of all, see whether the uterus is there or not. Because in HRT, you're giving estrogen. Unopposed estrogen can increase the risk of endometrial hyperplasia. You do not want that. So in those cases, you have to give combined HRT, where you have to give progesterone for endometrial protection. So always for intact uterus, you have to give estrogen and progesterone. This you have to remember. Then how do you decide if there is intact uterus? You see the bleeding pattern. She is bleeding regularly but still having PMS symptoms. Then you need not give any HRT, because that means if she's having regular periods, her estrogen levels are normal. Then you rule out other causes. Or if the patient is in a lot of distress, then you can give continuous continuous non-clinical symptoms are there, then you can think of giving sequential combined HRT for a long time, but it is not per se indicated at all, because it will serve as both contraception and give her some relief in her symptoms. So either you can just do counseling and you can think of non-HRT options, but if the patient is in a lot of distress, you can think of giving sequential combined HRT. If infrequent bleeding and non-cyclical symptoms, again you give continuous combined HRT. And you monitor for the side effects and bleeds, and accordingly do the adjust your treatment. Then, if at any point several changes in therapy is required, or bleeding is there is bleeding, unscheduled bleeding with HRT, then you have to refer these patients. If the bleeding is scheduled, then you can just call them for annual review. And for how long do you give these HRT? If the patient is under 50, then you give it till the age of natural menopause, that is 50. If over 50, then for at least 3 years and long-term use is necessary, then you shift to vaginal progesterone. For less than 12 months, period-free HRT, you can give continuous combined HRT tibolone, or which can also serve as if the patient is amenorrheic for less than 12 months. Then you can think of giving continuous combined HRT or tibolone depending on, and monitor for the side effects. If there is again acceptable bleeding or acceptable no bleeding at all, then again the patient will go for annual review, and you can think of referral if the bleeding continues. For urogenital atrophy, best is vaginal estrogen. If the patient is hysterectomized, both ovaries are removed, then you can give estrogen only HRT here. And one or both ovaries are intact, still menopausal symptoms, again, you can give estrogen because uterus is not there. You need not give progesterone. You monitor for the side effects, and these would be for annual review then. Okay, then this is again this is a table from one of the talk articles regarding what type of HRT you have to give. Perimenopausal women, you give continuous estrogen HRT with cyclical progesterone. For hysterectomized women, you give estrogen only. With subtotal hysterectomy, you can give estrogen only if no endometrium identified histologically at the lower margin. Otherwise, you have to give continuous combined if there is any part of the endometrium which is available. Post endometrial ablation, you can give either cyclical or continuous combined HRT. If the patient is progesterone sensitive, then you give Mirena plus systemic progesterone or micronized progesterone. Early menopause, then they might require higher dose of estrogen. Older women, you always have to, because you're worried about endometrial hyperplasia and endometrial cancer, so you start with the lowest dose and adjust accordingly. If there is potential risk of malabsorption, you go for non-oral like transdermal HRT or vaginal HRT. If there is low libido, then you have to give triatepiolone or testosterone. Non-responders to standard treatment, like young women with surgical induced menopause or iatrogenic menopause, in those cases you can give subcutaneous implants of estrogen. Then transdermal route is preferred in these patients where oral route might aggravate certain conditions, like if the patient prefers it personally, or there is a history of migraine, diabetes, hypertension which is controlled, existing gallbladder stones, deranged lipid profile, patient is very obese, smoker, previous venous thromboembolism, history of varicose veins. Relative contraindications that should be referred for specialist advice, where it is menopausal specialist who decide whether those patients should be given. So there is no absolute contraindication to HRT. If these conditions are there, when you think the HRT might be harmful, you have to refer for the specialist advice, like existing cardiac disease, active liver disease, SLE, previous breast cancer, previous ovarian endometrial cancer, undiagnosed vaginal bleeding, previous personal or family history of venous thromboembolism. This was about deciding what HRT to give and for how long to give. Now moving on to, if a patient presents with unscheduled bleeding while on HRT, how do you manage? This is the last segment of this discussion. So if you take a detailed history and physical examination, determine what kind of HRT they're using, whether it's sequential or continuous combined. If it's sequential, then you ask for a history and elicit if there is heavy, prolonged, or breakthrough bleeding in more than 2 cycles. Then you do a transvaginal scan to look for endometrial thickness. If the endometrial thickness is more than equal to 7 mm, you offer them endometrial biopsy or histoscopy with biopsy. If endometrial thickness is less than 7, you generally observe and follow up with review scans if the bleeding is persistent. If a patient is having unscheduled bleeding with continuous combined HRT, then you elicit about the duration. If it is less than 6 months, then you can just reassure if there is no other risk factor. If it is more than 6 months, then you do a scan, and here the cutoff for endometrium is 5 mm. If the thickness is less than 5 mm, you just think of atrophic endometrium or atrophic vaginitis causing this. Or if the thickness is more than equal to 5 mm, that's when you are worried and you would refer these patients for endometrial biopsy or hysteroscopy biopsy. So this was about the management of unscheduled bleeding with HRT and about this entire session about amenorrhea, uh, menopause and HRT. Hope this was useful. Thank you so much for your time.